Very, very good afternoon. And I'm delighted that I am with one of the most important, academically superb, clinically absolutely fabulous, and research-wise highly impactful in many areas, liver cancer, NAFLD, many areas, hepatitis, Professor Dr. Subrat Acharya, the Pro-Chancellor of the Kids University in Bhubaneswar, and the head of the Digestive Disease and Hepatology Department of the entire, I'm extremely in the Fortis Hospital, and I am delighted to be with a person who has made impact in the country and the world, from the word go, from MBBS to MD in Chandigarh. They're doing his DM and then not looking back, progressing without any, in non-stoppable progression with the God's grace. Subrat, I'll call you by first name. We are so close to each other. And I'll just start by asking to you, tell me, Subrat, don't you think that non-alcoholic steatohepatitis, we'll discuss about the name change. Don't you think it's the most important contemporary challenge in front of the diabetologists, the metabolic physicians?
Well, not only diabetologists, sir, it is probably important across the population in every discipline. It was first described as non-alcoholic fatty liver disease because way back in 1980 in Mayo Clinic, there was a brilliant pathologist called Ludwig. He got a biopsy of liver which was laden with fat. And then they used to see such fat-laden liver histopathology in alcoholics. But when he saw the histology form, it was written, he is a non-alcoholic, middle-aged male. So he rang the clinician and shouted, "You don't know how to take history." The clinician shouted back and told, "I know what is the history." And hence the term started non-alcoholic fatty liver disease. And it was in 1990, NIH, National Institute of Health, officially told, okay, let us call it non-alcoholic fatty liver disease. As the time progressed, we realized, people all over realized, non-alcoholic fatty liver disease is a manifestation of systemic metabolic dysfunction. Now, this group of people are more prone to develop many metabolic disorders like type 2 diabetes mellitus, cardiovascular morbidity and mortality, chronic kidney disease, polycystic ovarian syndrome, and so forth and so on. So then when multiple studies, it became very apparent that this is a disease which is prevalent in about 30% of global population.
Great. I think it's
a global epidemic. And there is no...
Can you tell us why they changed the name and what the current definition of this MA?
That's what I am coming to. Actually, what happened when people started seeing fatty liver disease all over the globe, and they found there are various metabolic dysfunction associated with it. So they knew it is a systemic disease. It's not focused to a liver disease or to a cardiac disease or to hypertension or to endocrinologist. It is a systemic disease.
Correct.
And liver disease is a manifestation of the systemic disease. And subsequently, as the plot thickened, a group of people from Asia started seeing fat in people who were non-obese. And it was seen in obese people. And obesity was a risk factor. Diabetes was a risk factor. And lo and behold, these Asian doctors who started looking at fatty liver disease by doing simple ultrasound. So there are lean people, and this bloody definition of BMI more than 25 as overweight, right? And more than 30 is obesity, right? Doesn't exist in them. And they told, well, they are not, they are lean fatty liver disease. But when the further evaluation was done, indeed it was found they have also metabolic dysfunction. Metabolic risk factor exists in them. Their visceral obesity is more because they don't have subcutaneous adipose tissue. Hence, last year, a world's expert from all over the world sat down together to define metabolic fatty liver disease and changed the term to MAFLD, the metabolic dysfunction associated fatty liver disease.
Good.
And they clearly define if you are over obese, by classical definition, for Caucasian that BMI more than 25, or for Asian BMI more than 23,
Correct.
or if you have frank diabetes mellitus, right, and you have fatty liver disease, okay, fine, that is obviously metabolic dysfunction associated liver disease. But in between those who have a BMI less than 25 or 23, they have also fatty liver disease. So they describe these are lean fatty liver disease, but they must fulfill 2 of the 7 criteria they define, which you define as a metabolic dysfunction. And these 7 criteria, Ashok will tell you, one is waist hip ratio. You know, in Asians, the waist, abdomen bulge.
Yeah.
So they define if the waist hip ratio for male more than 0.9 and female more than 0.8 for Asians, right? Or if you have dyslipidemia, you know that triglyceride and low HDL. Or if they are pre-diabetic, you know that also very well, the fasting more than 100 or postprandial more than 140 or hemoglobin A1C more than 5.7. And also, you know, metabolic dysfunction is associated is an inflammatory state. So they told CRP more than 2 and HOMA-IR more than 2.4. Out of the 7, 2 criteria in a lean individual is also metabolic associated fatty liver disease.
Absolutely fabulous, Subrat. That is my next question. What is lean FLD? And you have appropriately, very clearly, and absolutely crystal clear what is MAFLD and what is lean FLD. Now, Subrat, just a minute. What do you think about the global and the Indian prevalence of this malady?
So we are in much more trouble, Ashok, as Indians. Global prevalence obviously is increasing because of sheer obesity and sedentary habit and fine sugar dietary habits, which are actually causing insulin surge. And insulin is lipogenic. You people know better than me.
Yes.
But in India, all the people in diabetic associations has been students. Now, remember in your school, did you see a young boy with a tummy, bulged tummy?
No.
They were all thin.
No.
Right? Now you go and survey shows in Indian school, 30 to 35% of children in class 10th are obese because of the change in dietary habits. Now, that should be the focus of, I think, endocrinologists, gastroenterologists, and other people, that school children should be avoided to take this cokes, this aerated drinks, this pizzas, this noodles, this burgers, and this is causing high insulin surge, and insulin is lipogenic, and they are getting deposited.
Yeah.
And this is also, I will tell you, we have studied that childhood obesity is a risk factor for liver cancer.
Absolutely.
So that's the problem. What we are seeing as epidemic, and Indian population studies revealed that about 25 to 30% of Indian population above the age of 18 have fatty liver disease.
Now, Subrat, is there the effect of genetics? Because I just searched and I found some PLMP, 3X, etc. I'm not an authority on this. Do you think genetic has an influence? And the second question, is there any drug derived from the genetic aberrations?
Okay, it's a very good question, Ashok. These genes which you are reading, PNPLA3, this is patatin-like phospholipase dependent protein 3, is nothing but is actually a lipoprotein hydrolase enzyme. So what it does, it hydrolyzes triglycerides. Now, if you have, and all enzymes in human beings are polymorphic. We are polymorphic actually. We are human beings, but we are different.
Yeah.
So the enzymes are also polymorphic. And if you have a functional enzyme, because of mutation in the gene, it is in chromosome 22. And if there is a mutation, which has been also identified as RS708439 mutation, they are less functional. So they cannot break triglyceride, and triglyceride become glycerol, and glycerol get accumulated, what is called de novo lipid synthesis in the liver.
see. Good. Now it is very clear. Very
Now
clear.
there are other enzymes also in the process of hydrolysis, right?
Correct.
They are called, say, ABTL. This is another triglyceride hydrolysis, or ABCD 15H13. This is another form of hydrolysis. So if these enzymes which hydrolyze triglycerides are deficient, they will store fat into the liver. Problem is we don't have a target to change these genes
No.
because these genes are inherited.
Yeah.
So some people are prone to keep the fat in the liver, provided the environment helps. Environment is sedentary habit, dietary habit, right? Bad diet.
I get
So
it.
to have a
But my
clinician
question is a
and
very
an
critical
environment.
one now for the physician, Subrat, is how do we simply diagnose and what is new in the diagnosis? And the final thing, today we are told that ordinary ultrasonography of the abdomen might miss quite a number of NAFLD. One must do a fibroscan. I want to collect, the collected opinion on all these points, because diagnosis is one of the very important thing for us.
That's correct. You see, when liver contains more than 5% of fat by weight,
Yes.
or if histologically, if 5% of hepatocyte has fat, that is increased fat. It should be less than 5%.
Correct.
Now, an ultrasound will detect fat if the fat deposition is about 30 to 33%.
Oh, 30. Good.
Because the sound waves will not penetrate, so the image you will look as white, more white. Because once it penetrates, the sound waves will not come back, reflect back, which is the energy. So unless 30 to 33% fat is there, you will not detect a fatty liver disease. So, but it is a very good, easy, simple screening state, because this fat, if you detect in ultrasound, is reversible. Now, to detect accurate fat, the other imaging techniques are MR, or there are other imaging technique which you call a fibroscan, which is nothing but vibration controlled transient elastography. We call it VCTE, or ultrasound related elastography.
Yes.
Now, MR can actually detect, depending upon their nuclear changes or spectroscopic changes, right, small amount of fat, which is called PDFF.
Yes.
Proton density fat factor, because these are proton, right? And also similarly, fibroscan defines two things: the stiffness of the liver, which you palpate in your hand. So
Yes.
this is a machinery way of palpating the stiffness, because it throws these waves in a shear fashion, in a tangential fashion. So depending upon the stiffness of the surface, the amount of energy reflects back is more. So if there is a scar, it will be more stiff. So more shear wave will come back. So we can assess both fat as well as fibrosis in a fibroscan. So that's why it's very popular.
How
So
do you
in MR elastography,
interpret the fibrosis in the fibroscan? The simple message for the physicians. How to interpret? They said grade 2, grade 3, grade 4, beyond grade 2, take it positive. How do you interpret?
no, they call it, sir, F2, F1, F2, F3,
Yeah.
F4 of fibrosis,
Yes.
right? That is fibrosis score. You see, normal fibrosis score, which is based on doing thousands and thousands of normal population, it should be less than 6.
Less than 6? I
Yeah,
see.
6.
Was
Between
normal
6 to 8, right? You may have various reasons, but more than 8 is definitely fibrosis. If it is more than 8,
Correct.
and you are in trouble. If it is more than 12, it is cirrhosis.
Okay.
It is already high scar.
Correct.
So, in fact, it avoids invasive tests like liver biopsy. But liver biopsy, it has been correlated very well with liver biopsy in fatty liver disease, in hepatitis C, and hepatitis B. In fact, using it, we can avoid liver biopsy in about 70 to 75% of patients.
Good. Subrat, we know the stages of hepatocyte injury, inflammation, and fibrosis. I'm giving simplistic approach of a physician. Hepatocyte injury, inflammation, fibrosis. Is there any way of diagnosing early without liver biopsy?
You have absolutely put a finger on a spot. there are three elements. One is fat, one is inflammation, one is fibrosis. Right. Now it has been seen patients with liver fat who has inflammation and some fibrosis, they progress.
Correct.
But who has simple fat, they have other risk factor like cardiovascular risk factor or developing type 2 diabetes mellitus and other problems. So
And
we
also,
say
and also, Subrat, they die of the cardiovascular disease. Am
they
I
can
correct?
die of cardiovascular disease.
Correct.
If you follow fatty liver disease, over 20 years, 20% will die of cardiovascular disease, 20% will die of cancers, 20% will die of liver-related death, and 20% will die of other form of chronic disease like kidney disease and other problems.
Great way of teaching. 2020. Fantastic. Now, Subrat, tell me, I'm coming to a very important issue. Does liver enzymes, ALT, AST, namely, greatly help in diagnosis?
Actually, no. Liver enzyme, if you see a simple fatty liver disease with inflammation or even scar, can have a raised liver enzyme. Liver enzyme, if you see what is earlier called SGOT, SGPT or GGT, we called it AST and ALT. Name indicate aspartate and alanine transaminases. They are enzymes for amino acid transfers.
Correct.
For metabolism of protein and carbohydrate.
Correct.
They can be also leak out with little fat to the blood. So just raised transaminases make you suspect that there is liver injury, but not well correlated with liver injury.
Yeah. But
therefore, you need additional tests.
Yeah. Very important question, Subrat. When will you, the liver biopsy gives the final court of appeal, no doubt about it. But where will you say the liver biopsy is a must?
You see, there are many non-invasive tests today, therefore.
Yes, exactly.
The non-invasive test based on clinical scoring simple, there are clinical score.
Correct.
Now, I will give you some very basic clinical score. Like say, one score is very popularly known as FIF4. It is age, AST, ALT, and platelet. And there is a discriminant equation. It is available in your hand computer with the discriminant equation, it will calculate. If FIF4 score is more than 1.5, suspect fibrosis.
Correct.
Right. There is a test called APRI, AST platelet ratio. If it is more than 0.5, you suspect fibrosis.
Correct.
There is a NFS, non-alcoholic fatty liver disease score, NFS score, which consists of advanced age, male sex, right, AST, ALT, platelet, albumin combined together. So it also gives you a score. Besides this clinical score, there are blood tests also. Say extended liver fibrosis, ELF score we call.
Yes.
Which actually measures the various parameters of collagenization in the blood. And they are essentially TIMP, tissue inhibitor of matrix metalloprotease. When you have a scar as a GOBU in your body has a mechanism to also dissolve it.
Correct.
And those enzymes called matrix metalloprotease.
Matrix, yes. MMM.
And you can inhibit, body also tries to inhibit. So fibrosis is a dynamic process. Yeah. So TIMP, which is inhibits matrix metalloprotease, will go up. If you withdraw the cause, MMF will come down, but TIMP will stay for a longer period of time.
Correct.
And you have hyaluronic acid and procollagen type 3 peptide, which are dynamic changes which are causing collagenization or fibrosis generation, which you can measure in the blood.
Correct.
And we have identified if the value is more than 7.7, right, there is moderate fibrosis, and more than 9.5, quite advanced. So these are non-invasive tests.
When will you do real biopsy? For research purpose or for the purpose of treatment?
No, fibrosis may be sometimes very important. We do liver biopsy. You see, when you have a borderline score, these scores have a sensitivity and specificity of, say, 70-80%.
Borderline score, correct.
So if you in between score and you are very suspect that there is a fibrosis and you want to have a supervised treatment, and most important treatment, supervised supervision is necessary. Because no drug till now, Sosabgabu, has been able to do magic except weight loss, right? And exercise.
Yeah, I rightly said medical weight loss or surgical weight loss and lifestyle. I have got one question because you have last 5 minutes, Subrat. I want
Yeah.
to ask you, do you think, I just named the drugs. You give your frank opinion about it. Metformin, I think leave it. Pioglitazone.
Well, pioglitazone is a PPR delta, right, receptor. You know the role of PPR delta,
Yeah.
which will increase stem cells of fat stem cell and for large amount of hepatocyte. That's why they cause weight gain. But that store fatty acid. Once they store fatty acid, right, fatty acid stored to the liver decreases.
Okay.
Once the fatty acid direction or
Channel
road to
deficit.
liver decreases, well, that helps. And pioglitazone helps actually. It has been
Vitamin E.
analysis. But
Vitamin E has
metformin has not been shown to be of helpful.
What about vitamin E? Before I come to
Vitamin,
the drugs
again,
today.
vitamin A, long-term vitamin has, he in randomized control trial as an antioxidant because increased fat metabolism in beta oxidation of fat in mitochondria, generating a lot of reactive oxygen species causing liver damage, causing cell necrosis, which upregulates fibrosis, is they scavenge. And it is shown to decrease the inflammation, that is enzyme, not fibrosis.
Correct.
Right.
What about the newer drugs, Subrat? Are they going to change the scenario like GLP-1 RA? You are involved with so many trials. You are doing biopsies in the trials and also SGLT2 inhibitors. Well, GLP-1 RA, except one, Revels's, all are injections and SGLT2 inhibitors.
Yeah, there has been a trial. You know, GLP-1 obviously will decrease postprandial glucagon secretion and increase insulin secretion.
And weight also will come down.
It delays gastric emptying.
Correct.
It also works in hypothalamus and satiety centers.
Satiety, absolutely correct. I'm amazed, Subrat, I'm amazed at your mastery over the subject. And wish and pray for your further academic. Fantastic answer. How do they help? Are they going to change? Are they going to bring reversibility to this MASL?
That evidence has not come, but the clinical trials has shown both lira and semaglutide definitely has improved the fibrosis score and inflammation, right, to some degree. But question is, they're very expensive. Lira is an injection. Correct. Semaglutide, you go up 3 milligram per day to 14 milligram per day. Correct. And some people don't tolerate. I don't know whether you have noticed it or not.
I have noticed. Nausea, vomiting is a big issue.
Very big issue. So even though there are trials now, and very expensive, if you see my patients, where I used to work in a public sector hospital like AIMS or in a KIMS.
Yes.
Most of the people come back to me.
I'm delighted to learn, my dear friends, Subrat is the emeritus professor there. I'm delighted to announce this to the audience.
But they say, sir, we cannot afford this.
Yes, exactly.
Right. That's a big problem, even though clinical trials. Also, some trials done in the United States or Europe, if you cannot use it in my population, I don't consider it as evidence.
Exactly. After every journal club, you remember, Subrat, while 4 months I spent with you, Badri will ask whether it's adaptable to Indian population. Remember, the journal club. Otherwise, it's useless. Treatment adaptation to India was his concern, your teacher, my teacher.
It's a very important thing, Ashok Babu.
Yeah.
So just telling that.
Last question. Does caffeine help? Because there are so many things around caffeine. Does caffeine help?
It will be very interesting that there are 13 clinical trials now on caffeine.
Oh, really? Good.
Black coffee, scientific clinical trial.
I see.
And shown 3 to 4 cups of black coffee definitely actually has been claimed to prevent fibrosis, not fibrosis reversal.
Okay. Prevent. Right. That's enough. And you know, Subrat, you are also in charge of the division of human nutrition in AIMS. Whenever I visited, you had great interest. Now this Mediterranean diet, which is very difficult to practice now. Only the olive oil is 800 rupees per kg. So
not available.
Mediterranean diet. In any semblance of it that we can adapt.
You see, Mediterranean. What is Mediterranean diet? It is green fruits.
Yeah.
Olives,
yes,
right, and sea fish, which has a lot of omega-3 fatty acids.
We have plenty in Pondicherry.
That will be helpful. omega-3 fatty acids,
Yes.
right? Not omega-6,
Yes.
omega-3.
What about MUFA? MUFA?
Polyunsaturated fatty acid will be protective, right? But I will say it is more of omega-3 fatty acid which will help you much more, right? And omega-3 fatty acids are plentifully available in, say, seafood like salmon, like mackerel, trout, tuna, which are not available in India.
Correct.
I don't know in Pondicherry whether you get it or not, but it's also available in akroat, walnuts, and flaxseed.
Correct. Yes. Last question, Subrat, before I go, is about the bariatric surgery. We are not great protagonists. With the available new drugs, bariatric surgery has definitely come down. You must have seen. Now, what is the role of
It's a
bariatric?
big area in our subject. Endoscopic bariatric surgery. People
Yeah.
make money. Surgeons become
Exactly.
bariatric surgeons by doing not only gastroplexy, but they are doing bypass.
Yeah.
No doubt, studies, if you ask me for literature evidence or study evidence, it decreases insulin resistance, it decreases fatty liver disease, it decreases weight, it decreases insulin
But
requirement.
does it go back to the norm to back to square one after a few days if one doesn't maintain the lifestyle?
If you are going gastric sleeve resection,
Mhm.
stomach, making stomach small, stomach
Yes.
is elastic organ, it expands.
Correct.
And the diet lies here, sir. Problem lies
Absolutely
here in
correct.
the
In
brain.
the mind, in the mind.
So that's why you have, but they are doing a bypass. They are doing gastrectomy and putting jejunum straight into the remnant of stomach, right? So you don't have a stomach, right? That is probably helping, but that, well, that is a nutritional problem again. A lot of micronutrient deficiency, which you have to monitor continuously, makes life difficult.
Subrat, thank you very much. I think last 27 minutes have been absolutely prophetic. On behalf of the thousands of people, last year we had about 10,000 hits. The thousands of people pan India who have joined this to listen to you, I thank you, convey our sincere gratitude and thanks, and also congratulate you for your mastery over this subject and the way you have made it very simple. बोलते उसको प्रांजल, you have made it very simple, crystal clear. And on behalf of all of us, Subrat, thank you very, very much. But on behalf of all of us, I offer my sincere thanks, gratitude, and I know, and benedictions, because goodwill, our love and greetings for your continuous improvement. All the best to you, my dear friend Subrat. Tuina, the who is the source of inspiration for Subrat, and the love